platform of DBMCI. In this session, we are going to discuss the ENT recall question of FMGE exam held in December 2021. I am ENT faculty Dr. Sanjay Agarwal. Let us start with the first question. The question was, after removal of wax from ear by normal water, patient had giddiness and syncope. It is due to stimulation of which of the following nerve: facial nerve, Arnold's nerve, auriculotemporal nerve, and C3 nerve. Now we all know all these nerves, they supply what? They supply the external ear. And since they all supply the external ear, when you do any procedure in the external ear, whether you are removing wax or syringing or whatever, they all tend to get stimulated. But only Arnold, which is a branch of vagus 10th nerve, can cause giddiness and syncope. And that's why this is a correct answer. Right. Now, some people told me that one of the choices was Jacobson's nerve also. Jacobson's nerve is a branch of 9th nerve and it supplies the middle ear. It does not supply the external ear. We have discussed this. And so, if you do anything in the external ear, any procedure in the external ear, this nerve cannot get stimulated. And so, even if you are in the choices, this cannot be the correct answer. Moreover, even if you stimulate the Jacobsons during the procedure in the middle ear, still Jacobson will not cause syncope and giddiness because it is not supplying the heart and the lungs. It is the Arnold that supplying the heart and the lung, and therefore it can cause syncope and giddiness. So, Arnold's is a correct answer because it's a branch of vagus 10th nerve. Very good. Next one. Patient with the blanching lesion on siegle speculum. What is the diagnosis? Very straightforward. Glomus tumor, colostoma, tympanosclerosis, oropharynx. We all know when this blanching of a lesion on stimulation, this is a brown sign, and brown sign is a feature of glomus tumor, isn't it? And therefore, glomus tumor is the correct answer. Colostoma is seen in ancestral. It's a white mass in the middle ear, which is ever expanding, damaging the surrounding tissue like a tumor. So, it behaves like a tumor, therefore, the term is poma. Tympanosclerosis is due to complication of CS1. And in this, there is sclerosis of the tympanic membrane and the middle ear. And so, the tympanic membrane looks chalky white, chalk-like white tympanic membrane in this patient. Autosclerosis, of course, sclerosis of the middle ear, and there are signs like sword sign, paralysis, release, heart sound. Very, very popular disease. Lot of points, but nothing to do with blanching, isn't it? Now, this blanching of tumor brown sign in our app, in the eGurukul app, is discussed in two areas. It is discussed when we talk about siegle speculum, the functions of siegle speculum. It's mentioned there. And when we discuss glomus tumor, also there it is discussed. So, I think if you have attended the lectures and you have seen the app, you will have no problem answering this question. If you see this, talking about glomus tumor, these are the other signs in glomus tumor. This is PDF file of the eGurukul app. This is the quino sign, felt sign, brown sign. This is the one that we talk about. And brown sign you see in the app also is on using siegle speculum. The pressure increases in the external ear and there is blanches, tumor blanches. So very clear cut is given in the app and the PDF file of the app. It's given very clearly in the app and the PDF file of the app. No problem. Next question. The question was, what is trotter's triad? And the options of different triads were given. This is some people told me. And the options were given: hearing loss, trigeminal neuralgia, soft palate palsy, and facial palsy. Some people said the question was this: that which of the following is a feature of trotter's triad? And these choices, there is not an exact reproduction. One says unilateral deafness, trigeminal neuralgia, ipsilateral soft palate paralysis. Second choice is facial palsy, nasopharyngeal carcinoma, unilateral deafness. Third choice, endofibromatosis, unilateral deafness letter soft palate palsy. And fourth choice, angiofibroma, trigeminal neuralgia, and unilateral deafness. So whether it was this question or this or both, I'm sure if you attended the lecture, you know this is a very important, very straightforward question. Trotter triad is a feature of nasopharyngeal carcinoma, and there are three features: there is hearing loss, there is trigeminal neuralgia, which is facial pain, this is facial pain and hearing loss, and soft palate palsy, no facial palsy. So except, so this is not true. Rest were all the features of trotter triad. Hearing loss, trigeminal neuralgia, facial palsy. Right? And if they have asked like this, then again you know unilateral deafness, trigeminal neuralgia, and soft palate palsy. So this is the correct answer. It is a feature of nasopharyngeal carcinoma, but it does not have the facial palsy. It's not a feature of angiofibroma, so this goes straight away out. Right? So very simple, straightforward question. Now, very interestingly, in the last 4 exams of MCI, question on nasopharyngeal carcinoma has been asked in all the 4 exams. In fact, in one of the exams, there were 3 questions from nasopharyngeal carcinoma. This time they were asked only 1 question related to nasopharyngeal carcinoma. And that's why in all my lectures, in all my classes, whether it is TMB, regular class, fast year, whatever, I told you again and again that nasopharyngeal carcinoma you have to read, you have to read, you have to read. There's definitely going to be 1 question at least, maybe more than 1. They asked 1 question from nasopharyngeal carcinoma, and if you have followed my advice, I'm sure everybody must have read this tumor very nicely, and you have been able to answer this question very comfortably, no problems, isn't it? So very interesting. 4 times they asked questions from the same disease in 4 different exams, sometimes even more than 1 question. Isn't it interesting? Yeah. So this is again from the PDF file of the eGurukul app. So we talk about nasopharyngeal carcinoma, and this is where trotter triad is mentioned, and these are the 3 features as you can see. Isn't it? This is what is asked in the exam. So important, so easy. Next one. A 40-year-old female had labyrinthine fistula, positive to test and released positive, and again visited after 2 weeks with negative fistula test. And they are asked which of the following is true: false positive, false negative, true positive, true negative. Now, labyrinthine fistula is also called circumscribed labyrinthitis. Now, labyrinthitis can be 3 or 4 types. There is serous labyrinthitis, there's viral labyrinthitis, there's bacterial labyrinthitis, and there is this circumscribed labyrinthitis, which is the other name for labyrinthine fistula. It is usually a complication of CS2. There is a fistula between the middle ear and the inner ear, and that's why it's called labyrinthitis. Right. Now, because this labyrinthitis, the patient will have sensory neural hearing loss, inner ear, and that's why Renis is positive. Renis positive proves it is sensory neural hearing loss. And because there is a fistula, the fistula sign is true positive. The patient has true positive fistula. Now, this fistula sign becomes negative. If you remember, when we discussed in the lecture, we talk about true positive fistula sign. FS is fistula sign. Then we talk about false positive fistula sign, and we talk about false negative fistula sign, if you remember. And we have 3 columns. And I give you causes of true positive fistula sign, false positive fistula sign, and false negative. True positive fistula sign, the first example that I've always given is labyrinthine fistula. So this is exactly the question. This labyrinthine fistula, and therefore it is true positive fistula sign. And because this is labyrinthitis, you will have release positive. I'll talk about this also. Now, suddenly it becomes negative. Fistula sign becomes negative, so it has to be false negative. And false negative fistula sign, one of the conditions is dead ear or severe SNH. Severe sensory neural. So from here, it has progressed to this. So this is a patient who came with labyrinthine fistula having true positive fistula sign and release positive. became dead ear because it is negative fistula. It became dead ear. Now, release, when we discuss, release is positive and negative release. Positive is what? AC more than BC. And what is negative release? Opposite of this, BC more than AC. We have discussed this. Now, both can be true positive, false positive. Similarly, true negative, false negative. We all know this, we have done this. When we get true positive, normal. False positive, sensory neural hearing loss. True negative, CHL. False, dead ear. We know this very well. We have done in the lecture very nicely. Now, this is a patient of middle ear disease, so it cannot be normal. This is out of question. Normal is not possible. It is possible in is, if normal is not possible, the only other possibility is SNHL. So that's why I say the patient is having SNHL. That's why it is positive release. And this is proven by the fact that labyrinthitis, inner ear inflammation. Now this becomes dead ear. This becomes dead ear. So in dead ear, what is the finding of release? In dead ear, it is false negative release. False negative release. So this is the correct answer. It is a false negative release. Any patient of labyrinthitis fistula with positive sign, if the fistula sign becomes negative, it is dead ear, and in dead ear, the release is false negative. Now the exact MCQ I have discussed in all my TMD paper, especially the one for PG. This question has been discussed exactly the same question in the TMD paper. It's almost a reproduction of the same question. Now there is a very similar question. So this is a very similar question here, that which is true for release. Now in normal ear, it is true positive, which is this one, positive, true. In SNH, it is false positive. We just discussed this. Here, we have discussed this here. I'm reproducing this one again. So this is also true. False positive. This is positive. This is also positive. In CHL, it is true negative. This is more than AC. This is true. This is true. In dead ear, what is the finding? It's false negative. Remember, in dead ear, it is false negative. So it should be BC more than AC, and not AC more than BC. So this is not true. It is except this one. It is not true. So again, it's a very similar question. These two very differently. I'm not sure both were asked or only one of the two, and the students are confused. Some told me it is this question, some told me it is this question, some said both, but whatever, both are very easy questions, and they have been discussed very clearly in the exam. It is showing here. This is again from the PDF file of the eGurukul app, where everything about release is discussed. If you remember, in the class when I talk about investigations of the ear disease, I divide into two parts. One is hearing test, and the other is a vestibular function test. You remember this? Recall this? And I give you the names of hearing test, number of names of hearing test, 5 names, number of vestibular function test. One of the names is tuning fork test. And then I tell you, out of all these 8, 9, 10, 12 question names that I give you, I always tell you the most important test from the exam point of view where they are likely to ask questions is tuning fork test. Did I tell you not? And see, they have asked a question from tuning fork, not one question, two questions from the tuning fork test in this common exam. So again, I've highlighted this point in the exam, in the class, many times that please read the tuning fork test properly. I've discussed everything in great detail. Slightly difficult topic, but I always tell you that if you attend the lecture properly, you can answer this question very, very easy. In fact, the questions were discussed in the class, but the same questions. So I hope that you've been able to answer comfortably without any problem. Next one. A 16-year-old boy has symptoms of recurrent epistaxis. Mass can be seen, and the patient is breathing through the mouth. What is the probable diagnosis? I don't think anybody will get this wrong. I told you a boy which is juvenile male with epistaxis, I tell you in the class so many times, is straight away juvenile nasopharyngeal angiophyte. Straight away juvenile nasopharyngeal angiophyte. Nasopharyngeal carcinoma is lymphadenopathy. Remember? And this was asked last year. In the last year, they had asked about the lymphadenopathy, the most common presentation of nasal carcinoma. Nasal polyps they present as nasal obstruction, blockage, nasal block. And glomus tumor is an ear disease. It is nothing to do with nose. In glomus tumor, there is nothing in the nose. We have discussed the glomus tumor, that brown cell, that is glomus tumor, ear disease. And another question: where is the little area located? Kiesselbach plexus, lateral side of the nose, anterior part of the nose, or posterior part of the nose. And everybody knows little area as Kiesselbach plexus. Lateral of the nose has Woodruff's plexus. Woodruff's plexus is a venous plexus. So I'll show you the image here. You can see this is the again PDF file from the eGurukul. This is a nasal septum, and this is a diagram that I drawn in the class. And this is your little area with Kiesselbach plexus. Little area. Everything is given here. Same. And this is the most common site of nasal bleeding. That's why this is very, very important. We discussed epistaxis in details, causes, cause, site. This is the most common site of epistaxis. That's why this is important. And the arteries that form this plexus, this area, everything is given in your lectures. Very nice. Now, there are two similar questions again. This is one where the child came with recurrent otitis media, and the next step, recurrent otitis media is serious otitis media or blue ear, isn't it? And we all know that blue ear, the treatment of choice is myrinectomy, with grommet, with adenoidectomy. Antibiotics is usually not used in blue ear because blue ear is a sterile fluid. Remember sterile fluid? The antibiotics is used in AS1, it is in CS1, but not in blue ear. Tympanotomy is done for CS1, and incision drainage is not done in the ear. Incision drainage is done for either abscess or hematoma. Even if you do incision drainage, the tympanic drainage, we call it myrinectomy. But only myrinectomy is done for AS1, not for blue ear, not for recurrent. Isn't it? And if you remember, when we discuss otitis media, there are 5 types I talked about. Acute otitis media, this blue ear, serious otitis media, safe CS1, unsafe CS1, and tubercular otitis media. And I keep telling you, out of these 5 types of otitis media, this one, blue ear is the most popular disease. This is the one they ask you most commonly. And I also tell you, in blue ear, the most common question is the treatment options. Okay? Exactly what I predicted in the class has been asked. Out of the 5 types of otitis media, the biggest topic of here, I will read this topic very nicely, and in this topic you have to know the treatment of choice, which is exactly the question. We have a similar question, very similar. A child with high arch palate and is mouth breather. What is the next line of treatment? And again, what is arch? What is that? See, I told you that in adenoid hypertrophy, two things can happen. It can lead to station tube block, causing blue ear and hearing loss. Actually, is hearing loss. The last question is about this one: hearing loss in the recurrent otitis media. So, what do? You do myrinectomy with grommet plus adenoid. Both grommet plus adenoidectomy has to be done. The second thing it can cause is it can cause adenoid phases and mouth breather. So the patient is presenting with this one. Adenoid faces, high arch palate proves there is adenoid faces. There are 5 features of adenoid faces: high arch palate, crowding of the upper teeth, pinched nose, collapsed ala, and hypoplastic maxilla, and dull expression. So what do? You have to do adenoidectomy because it is adenoid hypertrophy, so you have to do adenoidectomy. Now, often when you do adenoidectomy, because you are suspecting in this patient This one also, so we do this also. So the correct answer should have been adenoidectomy plus grommet insertion. This is the best answer, but this I believe was not given the choices, and therefore out of this one and this one, adenoidectomy has to be done because there is no mention of hearing loss. There is no mention of hearing loss. We assume the station is still not blocked. This blue ear has not happened yet. So why do a meningotomy in grommet? But ideally we do it. It depends on the language and the choices. So with this language and with these choices, adenoidectomy is your best answer in this case. But in the previous one, this question, where there is clear-cut mention of a otitis media, recurrent otitis media, then you have to do grommet insertion with adenoidectomy. If this choice was given in this question, if this question had this choice, then this is your best answer. This is your best answer in this question also, but I believe it was not given in this. And therefore, adenoidectomy becomes the better answer. Right? So this is again from the PDF file of the eGurukul, showing your meningotomy and grommet. This is what I'm talking about. This is the best answer for mouth breather and blue ear and all that. So clearly, and the images are shown. So I'm sure you remember this very nicely. Next one. Patient has paralysis of the right vocal cord. What is the immediate treatment given to him? Observation, tracheostomy, type 1 thyroplasty, and gel form. Again, depends on the language. If this is the question, when we talk about vocal cord palsy, if you remember that we talk about 4 types of vocal cord palsy: unilateral, abductor palsy. Remember? Then bilateral abductor palsy. Then unilateral adductor palsy. And bilateral adductor palsy. Remember, we are dividing into 4 types, and then for each of them we describe the position of the vocal cord, the main symptom, and the surgical treatment. And this is the most common type. This is due to recurrent laryngeal nerve palsy. So if the patient says right side palsy of the vocal cord, it's unilateral abductor. This is the one it is talking about. What is the main symptom here? The main symptom in this is hoarseness, and it becomes normal in few days time. Remember, normal in few days time due to compensation by the others. So because it's going to become normal, why do anything? That's why observation, which is way too much. So this is the correct answer. Assuming this is the language of the question. In bilateral adductor palsy, dyspnea is the main complaint. In this we do tracheostomy. And the others are like Kashima's, remember? Kashima's type 2 thyroplasty. You remember all this. In adductor palsy, there is hoarseness, but this one does not compensate to become normal. So in this one we do type 1. Type 1 is done in this, and gel form is also used for this. Injections of gel form and collagen and Teflon and all this is used for this. In bilateral adductor palsy, there is aspiration and aphonia, and for aspiration we do total laryngectomy. So if you follow this from the exam, from the lecture, you straight away know that if it is one side vocal cord palsy, the voice is going to become normal very soon, and so you do nothing, you wait. And I keep telling you that vocal cord palsy is a very important topic. Questions are very frequent, and this is the most important thing. And if you remember, I talked about the 8th, 10th nerve branches, RLN and superior laryngeal nerve. Superior divides into internal and external, and RLN remains RLN, and then we talk about the problems and the symptoms. So it's based on that. It's a very simple question. Now, a similar question was asked in the NEET PG also. So that proves that vocal cord palsy is a very important topic. Then, battle sign is seen in which condition? Edema over mastoid process, bruise over mastoid process, periorbital blood accumulation, or blood behind tympanic. Battle sign is due to fracture of skull base or you can say temporal bone fracture. So in this case, the emissary vein of the mastoid gets damaged. Emissary vein of the mastoid gets damaged. The blood oozes out, that causes bruises and blue color. Bruise and blue color of the mastoid. And this is called battle sign. Very predominantly discussed. Everybody knows this. Edema of the mastoid process is Gray-Singer sign. This is Gray-Singer sign. And this is seen in lateral sinus thrombosis. Blood behind the hemotympanum is called hemotympanum. And this also is due to trauma, but this is not a grace, this is not a battle sign. Right. Now some people, this is your battle sign. Image, you can see bluish color of the mastoid. Some people say this, the question was differently. They said battle sign is a feature of battle sign is seen. Which are the following conditions? So in that case, it is seen in skull base fracture or temporal bone fracture, or there is edema, bluish color of the tympanum, mastoid, whatever. So if you know this, you can answer with whichever way the question is asked. You can still answer this question. The image is also important of battle sign. Next one. This instrument is shown is used for the following procedures or surgery: decrocystorhinostomy, chest enucleation, or e-visceration. Now this is an ophthalmology question. I'll just check it up because the answer is decrocystorhinostomy, and decrocystorhinostomy is also done in ENT. It's a very popular procedure in ENT also. I thought I'll just tell you. I'm sure it is discussed in ophthalmology very nicely. This is syphilis bone punch. And the surgery is done for decrocystorhinostomy. It is done for decrocystitis. Decrocystitis is due to blockade of nasolacrimal duct, we all know. So in this case, we have to make a bypass. Because the nasolacrimal duct is blocked, we have to make a bypass in middle meatus. This is a very popular question. Decrocystorhinostomy, rhinostomy, making an opening in the nose, is done where? In the middle meatus. And so you have to puncture, or you can say fracture the lacrimal bone. Lacrimal bone has to be punctured. Through that you create a bypass. So bone punch, we need a bone punch for this. There's a very similar kind of instrument called back punch, back biter, which is used for face surgery. And that looks very similar. So if you're not careful, which is used for face surgery, then you can get mistaken. Back biter is called. So it looks very similar. Right. And all this will be discussed in ophthalmology, I'm pretty sure. Then a white membrane in the oropharynx that bleeds on peeling is seen in membranous tonsillitis, candidiasis, oral thrush, infectious mononucleosis, diphtheria. Now they can all cause membrane in throat. That's why they are choices. They can all cause membrane in throat. Now, usually these three, they have what is called true membrane. So membrane is actually formed by the tissues around the disease. The tissue around the disease, they expand over the disease area and form a true membrane. So there is no much inflammation, and so if you peel it off, they will not bleed, and therefore do not bleed. Usually, not that they can never bleed. Usually they do not bleed. But diphtheria has a false membrane. It's not a true membrane. It's a false membrane, also called pseudomembrane. Why it's called false membrane or pseudomembrane? Because it is not the tissue. It is formed by the exotoxins of the, because diphtheria produces toxins, and therefore there is inflammation around it. and this causes bleeding. So because of the first membrane, the bleeding is seen. That's the only difference. Otherwise, membrane in the oropharynx can be seen in all of them. But diphtheria is the only one where it bleeds on peeling or even in touch. If you touch it, it might bleed. So that's why this bleeds on peeling is very, very important aspect in this question. In the NEET PG last year, 2 years back, they had shown a membrane image and they asked what is the cause of this membrane, what is the diagnosis. So you should be able to identify the image also. And you can see these are the two images. One is membrane, this is membranous tonsillitis. Membranous tonsillitis is also called streptococcal tonsillitis because it's caused by streptococcus, and this is the most common cause of throat membrane. Now, diphtheria is not the most common cause of membrane in the throat. A lot of people think this. But look at the two membranes. In membranous tonsillitis, it's a very thin membrane you can make out. The margins are very clear defined, and there are patches of normal tissue in between. Whereas diphtheria, you can see, is a very well-defined, clear-cut, thick membrane, dirty white in color as we call it. And if you try to peel it off, it will be black. So the images are also very, very important. You should be able to differentiate between these images of diphtheria and membranous tonsillitis. Right. Next one. Identify the arrow mark structure. Straightforward, clear-cut question. This is epiglottis. Vocal cords are these. These are the vocal cords. This is a thyroid cartilage. This is a cricoid. And probably this is hyoid bone. The image is not very nice that I've chosen, but this is probably the. Now, anatomy of the larynx is very, very important. We show you in anatomy, we show you in ENT. We help you identify all the cartilage and the bones in the anatomy. So you should be able to identify them very easily, especially epiglottis, because epiglottis has many other special features, like it is the only completely elastic cartilage of the larynx. All this we discussed in the class, and therefore it does not calcify. This was a question asked in NEET PG. It does not go calcification, and it does not develop from the fourth branchial arch. It develops from what is called branchial eminence. It develops from branchial eminence. So because epiglottis is a very special kind of a cartilage in the larynx, different from rest of the cartilages, questions on epiglottis is very, very commonly asked. So you can expect a question from epiglottis, and identifying epiglottis is very, very important because of thumbs. In epiglottitis, this epiglottis becomes swollen like this. It becomes swollen like this, like a shape of the thumb, and therefore it's called thumb sign. This is another very important MCQ in all of this. Right. Okay. And X-ray shown the child who has ingested the coin. Most likely site of the foreign body is larynx, trachea, esophagus, bronchus. I'm told it was only one X-ray view, the lateral view like this one, and the edge of the foreign body was in the coin like this one. See, when you look at the coin from the end, the coin looks like this, isn't it? The coin is like this, round. But when you look at the edge, it is like this. So on the side view, if you see the edge of the foreign body of the coin, it is esophagus. In the larynx, the opposite is true. So I show you here. See, this is AP view of foreign body in larynx. You can see the edge of the foreign body on an AP view, and this is AP view of foreign body in esophagus. See, both are AP view, but in this you see the whole round thing in esophagus, and the larynx you see the edge. So this is how it is going to differentiate. But in the exam, it was neither of the two. It was this image. This is lateral view of foreign body in esophagus. And this was the question that I produced. So when you have these two images together, both AP view and the lateral view, then it becomes very easy to diagnose this kind of thing. So whenever you get X-ray done, you always get both the images. Although in the exam they ask only one image, but you always get both the images done. And this is right main bronchus foreign body. And this is the most common site of foreign body in aerodigestive tract. They ask which is the most common site of foreign body in the aerodigestive tract. It is right between bronchus. You can see it not in the midline. On the side, it's very easy to diagnose. So laryngeal foreign body, esophageal foreign body, bronchial foreign body, all the exercises are shown. Very easy and very important for me. Now this completes all the ENT questions that were asked in the exam. However, there are two more questions like this one. There is a question on Malampatti score, but this is anesthesia question. So it will be discussing anesthesia. But because the question said the patient was undergoing tonsillectomy surgery, and then on when the patient, when the anesthetist was trying to intubate, he examined, they gave him one of the images, I don't know which one, and they were asked about class, I think. I'm not too sure. Class 1, class 2. And in class 1, you can see the entire uvula. Class 2, the uvula is not releasing. In class 3, the subplate is hidden. Class 4, nothing is seen. So in anesthesia, I'm sure to discuss in details properly. I'm just telling you there was a question from here, so you can know about this. And similarly, there is another question about vitamin B12 deficiency, where the tongue image was shown. In vitamin B12 deficiency, the tongue is beefy red with fissures in the tongue. And I'm told that choices were like vitamin C deficiency, vitamin B12, vitamin B6. I don't know what other the choices were there, but according to what I've been told, it was about beefy red and fissure tongue, so it is vitamin B12 deficiency. So you should know this also. In fact, I think there were 5 to 6 questions related to vitamin deficiencies. I'm sure this. I'm told this. There are a lot of questions about vitamin and vitamin deficiency. Anybody who had read the vitamin very nicely, properly, would have been able to answer all these questions and done very nicely, I'm sure. So vitamins are very, very important from PSM point of view, from periodics point of view, from biochemistry point of view. So vitamins are very, very important. Also sometimes from the ENT point of view, like this one. Right? So this will complete all the ENT questions. So I hope that this session was useful. I really hope that you have done very well in your exams and will come out with flying colors, so that next year we can all prepare for PG exams. So if you clear the exam with good color, let us know. Join in DBMCI so that we can all prepare for PG entrance exam next year. So hope to see you in the PG entrance exam class. Till then, thank you. God bless you. And stop.